So what we have developed within the Cambridge and Peterborough CCG is a template for entering key data for patients approaching the end of their lives. If you, as the GP, and there's a similar slightly shorter template for community nurses, enter data here, with the patient's consent, this data will be shared with out-of-hours 111, emergency admissions units, ambulance crew, and other out-of-hours services. And it acts as a number of different things. It's a place to record your consultation with a patient. So it's the part of the clinical record. Number two, it's for the sharing of that information across the healthcare system because it's all read-coded, it can be shared. Number three, it's kind of a checklist for us as clinicians to remember some of the aspects that it's easy to forget, like have I addressed DNA CPR? Have I thought about the DS 1500 for fast track attendance allowance? And the fourth is it's a resource for palliative and end-of-life care with a number of documents embedded, including the so-called yellow chart for community prescriptions and a number of other documents that might be appropriate for you to give to the patient or their loved one after death. So it's a one-stop shop for palliative and end-of-life care. I have timed myself on several occasions and it takes a maximum of 2 or 3 minutes to complete, and I'll now demonstrate this with a dummy patient in my practice. So I'm just going to talk us through the template for end-of-life care that has been designed for GPs to use. There's a slightly different version for community nurses. And so what I've done in SystmOne is to open up one of our test patients. This is not a real patient, and I've just simply opened up the patient record, and there is some information that I've already entered about this patient from when I previously saw them. I've just been to see them again, and what I want to do is to record some updated information in the template, and what is entered in the template is read-coded and shared across the healthcare system with patient consent. So to access the template, go to the blue button here for the template dashboard and go to the Cambridge and Peterborough template dashboard there. And the second tab here, which is C&P, ES and CCG, and has down here the CCG templates. Now, just at the moment, there are actually two red stars. So red star is for end-of-life care. There are two versions of the template. This is the new version that will be replacing the previous one as from the 1st of April when the 2% DES is withdrawn. So I'm just going to demonstrate the new version of the template. And here we are. I've opened it up in the patient record, and you've got 1, 2, 3, 4, 5 tabs. We reckon it takes about 3 to 4 minutes to fill in the key information. And obviously record sharing and consent for record sharing needs to be in place for this to be of maximum use. Firstly, is this a cancer or a non-cancer patient? If you click on the space there, you'll see that on a little while ago I specified that this was a cancer patient, so I don't need to update that information. And I click on this box here, which is the brief summary of the main life-limiting illnesses, which is the information that colleagues in 111, out of hours and A&E will see, which is a sort of précis. So this is a lung cancer patient with cerebral metastases, no further cancer treatment options for palliative care. So that remains the situation. I'm not going to update it. Are they on the practice QOF register? Yes, they are already as of the 6th of March. And yes, I've also ticked that as of the 6th of March, they've had an MDT review. But on the 6th of March, this patient was Gold Standards Framework Amber. So there's red, amber, green, green being stable disease, months prognosis, amber being deteriorating, weeks prognosis, and red being rapidly changing days prognosis. So I'm going to indicate here that this patient is now gone from amber to red. And where are we with DNA CPR? If you click on these blue buttons in the template, you access information leaflets, and I should have shown this one first, which is a leaflet around sharing of information that you can give to patients. It deliberately doesn't mention end-of-life care, but that's something that you might want to give out to your patients. So that's that one there. Here, if you click on that, that brings you to the CCG library of documents, DNA CPR form, and there you are. It calls up the DNA CPR form. We're going to develop this shortly so that the patient's name and address is already incorporated. So there's the DNA CPR form. Here you indicate what their CPR status is. And so on the 6th of March, they were already DNA CPR. No need to update that. Is the patient aware of prognosis? Yes, they were, and they still are. No need to update that. So here, their preferred place of care is home. And today that remains at home. And in terms of their preferred place of death, they did say that was home. They're now saying they'd prefer to die in hospice. So I click on that. We already have discussed DS 1500 living allowance, and actually I've completed it today, so I've updated that. And there is opportunity here to record their religion, which for certain religion traditions, particularly Jewish and Muslim, is important to record because they need burial before sunset on the day of death, if at all possible. These two boxes down here are really quite important. So there's the current problems and management, or the coordinated support plan, and the anticipatory care plan. And what I've written in here is, in terms of the current problems of management, currently living at home with daughter who calls in daily and does shopping, independent and mobile around the house, minimal symptoms only. So that's how the patient is today. And the plan, when I saw them last time, was if deteriorated, he's expressed a willingness to go into a care home. If recurrence of confusion from cerebral metastases, for no more radiotherapy, hospice are aware and may be able to admit. So what I'm going to do here is I'm going to update the anticipatory care plan, and I'm going to put less well and more confused today. Hospice have a bed for admission tomorrow. And I'm going to save that. The next tab is the prescribing tab. And the beauty of the prescribing tab is on the left here. We have prescribing for just-in-case medications. On the right, prescribing for syringe drivers. And up here, we have what people will know as the yellow prescription chart, which we can print off from our computers. The first page here is the prescribing guidance that's been agreed by all the specialists in palliative care. It already documents the patient's name, address, and the GP. And here is the yellow chart that you'll be aware of. So print it off and fill it in by hand. You'll see that the date is there and the page numbers are there, and leave it in the patient's home. It won't be on yellow card, it'll be on white paper, but our community nursing colleagues are aware of this. Now, say I want to do some more just-in-case prescribing. This has been set up so that here, if I click on this, this is giving 5 ampules of 10 milligram diamorphine, and it is suggesting a starting dose of 2.5 to 5 milligrams 2 hourly. You can overwrite that if you think appropriate, but if you think that's appropriate, you can click on that and it will save. And then if you want some midazolam for anxiety or agitation, the suggested dose is 2.5 to 5 milligrams 2 hourly. So I want 5 of those. Glycopyrronium for respiratory secretions, that's recommended. 200 micrograms 2 hourly as required. I want 5 of those. And some haloperidol injection for nausea and vomiting, and I want 5 of those. I'm not going to go for sublingual lorazepam because perhaps I don't think that's clinically indicated. I do need some water for injections, which will give me 10 ampules of that. And then at the end of this, if you just press print, then all that just in case prescribing will be available. You can do the same with continuous subcutaneous infusions, and you can see there's recommendations: diamorphine or oxycodone, midazolam or levomethomazine, and the 3 different drugs we use for nausea and vomiting. So this really enables very rapid prescribing. The first tab is the most important in terms of the clinical information. The last 3, to be honest, you can omit if time is tight. And so here, this is referrals. You can do some electronic referrals within SystmOne, in this case to community nurses in Huntingdon, or community palliative care in Arthur Rank, or in East Cambs and Fenland, or in Cambridge. But normally I think you will probably want to use, here we go, I'm referring here to a Word referral to the Huntingdon Palliative Care team, and it will upload the document. This is the palliative care referral form for Huntingdon with the patient's name, and you just fill in the rest of the referral form and send it off. So that's the referral tab. Relationships here, I've already made a note of the carer, the next of kin, who is there. You can add some more information if you want. Blue document here is a 1-page concerning what to expect when someone is approaching death. It's an information sheet for patients and families if you think that's appropriate. And then there are 2 websites here, not documents, but this is a website that takes you to lasting power of attorney and information if that's appropriate for the patient. And then the last tab is after death. I've already got their preferred place of death to be home, and then what we can record if the patient has died is where they actually died, and then that will enable you to enter a comment here in terms of the variance between their preferred and actual place of death. The cremation forms are here, so there's form 4, form 5 is there, and then there's another document that you can click on which has information concerning bereavement services available. So it comes up here in terms of bereavement support services in Cambridgeshire and Peterborough for adults, for children, for parents and adults, by trauma, by suicide, all sorts of the Samaritans and other support services available there. And then you might like to, after your patient has died, to discuss as a team their care they had before they died, and have you as a team thought about bereavement support. So just to emphasize, it's this first page is the main one. It takes 2 to 3 minutes maximum to complete. You then go on to the prescribing tab if you need to prescribe. Referral, if you need to make a referral, that's fine. If not, you can go straight on to relationships, which is about the carer. And here in relationships, I should have mentioned, but I didn't, we have information about their housing. So she's living alone, he's living alone with help available. And the informal carer is aware of prognosis. And then the after death. And then you can just simply save that information. Now, it's asking whether you want to create a special patient note. And as we noticed when we opened up the record, they already have an end-of-life care special patient note. So the answer is we don't want 2 of those. So I'll say no. The DS1500 also precipitated that question. Shut this down. And then what you can find, if you go into summary printout, there's another red star. And this is the Cambridge and Peterborough End of Life Care Summary. And this is the information that will be visible to 111 and out of hours. Headline here is lung cancer with cerebral mets. That's the data we put in. And the second thing is the current problems, disability and management, and anticipated problems, and resus status. And this documents here that on the 6th of March, he was yellow, now he's GSF red, and the rest of the information is there. It documents all the injections. I've done some last time, I've done some more. And that is the information with the most important things at the top that 111 and out of hours can access. And if you're looking after a patient in a care home, you can simply print this summary and leave it in the patient's record in the care home. So in summary, this template is for recording of clinical information, for the sharing of information across the healthcare system. It's a clinical prompt to remind you of some things that you might forget, like perhaps resuscitation status or DS1500. And it is a resource for those embedded documents like the DNA CPR document that's immediately available.